Hi, everybody. Thanks for joining us. I'm Mike Stone. I'm the VP of Education and Sonography at Butterfly and an emergency physician. And I'm super excited to have Rachel Liu with us. Rachel, you want to go ahead and introduce yourself?
Hi all. Thanks to Butterfly and Mike and everyone for having me. I am I guess, the director of ultrasound education for point of care ultrasound for Yale School of Medicine, meaning that I kind of focus on medical school students and curricular development. I'm also the fellowship director for emergency ultrasound with the Department of Emergency Medicine at Yale School of Medicine. And so happy to kind of take you through some of what we do on a regular basis.
Awesome. Yeah, for context, Rachel, I'd be hard pressed to come up with how many hours of our lives we've spent in QA. But do you want to just give a quick overview of sort of what this means to us, what the role of reviewing images and why it's important and how we usually go about this in person with people?
Yeah. I think image review is really quite an essential part of our job for anyone who's running an ultrasound training program. Here, anyway, we have all our residents performing ultrasound electives. We have quite a few students, and of course our fellows performing scanning on a regular basis. And we try to perform quality assurance on close to 100% of them to make sure that scan technique is appropriate, to make sure that trainees understand how to troubleshoot when they encounter some image quality problems, and also that they understand pathologic versus normal, and can make maybe some clinical calls on that. So reviewing these images is really essential to assess all these kind of areas of competency or proficiency, and also making sure that they clinically apply their findings to a patient's course.
Fantastic. So with that said and that overview, let's launch into doing some image review. While you're getting your screen sharing going, I just heard recently about the project that you were working on with a number of different emergency medicine training programs to continue. COVID's obviously posed a challenge, not only the obvious challenge in terms of patient suffering, societal changes, the healthcare strain, but has posed a real challenge in terms of educational programs where residents would typically come in and do an educational scanning shift where they'd come in and participate in scanning patients in the emergency department for really educational purposes to get their skills up. But you're not really going to have patients coming in and scanning if they don't need to be in the department in the time of a highly contagious pandemic. So talk to us a little bit about how this project came about and what it really was, and then we can launch into some specific studies.
Yeah, this was really formed quickly. I think it was a really good feat. So what happened was right when COVID started hitting, kind of early March, we realized across the nation that we would have to close our ultrasound rotation programs for in ED or in hospital scanning. And so we were trying to devise other methods and other educational arenas where we could provide some scanning for technical guidance, because most of, as we know, ultrasound proficiency is with the hands-on part, not necessarily with the whole didactic lecture-y knowledge-based part. And so there was an email that appeared on the ACEP, which is the American College of Emergency Physicians listserv, asking if institutions wanted to partner, and that was put out by a group from Emory. And from those responses, probably about 15 institutions were really interested in partnering so that we could offload the work that it would take to individually provide education to our residents, and share it across several institutions. And it was really cool. So every day, the ultrasound rotators got a lecture by one of us from the 15 institutions. So they got some expert teaching there with expert guidance. And then uh, I got to partner with Butterfly, who graciously loaned 10 of the programs, the ones who responded, some IQs each. so that the residents would have something to scan with outside of the hospital. And so there were probably about 29 to 30 residents who got to take advantage of this over March to June period. And they scanned about 976, so almost 1,000 scans appeared in this
Wow.
collaborative. Yeah. So you'll probably hear more about it later on because we'll try to kind of publish some of this stuff. But I thought for a very quick thing, a quick adjustment to education, this was pretty brilliant. So I have some of their images that we can go through right now if you want to.
Yeah, let's jump in. Let's get to some image review.
Yeah. So this one I kind of like because Johns Hopkins were really cool about developing some challenges to make their rotators engaged in kind of out of hospital scanning. And so what these guys had to do was they had to scan their full bladder. So here, this is a bladder in a transverse view. And if I had to quality assure this, I could say that maybe they could decrease their middle and far gain a bit because we have a lot of posterior acoustic enhancement here. But, at least they're fanning through the bladder somewhat. And looks like they performed some measurements of the width and the height here. So they were able to figure out the butterfly measurement system and good labeling. And then they changed to a sagittal view of the bladder so that they could get height rather than depth, which they had done earlier. So again, posterior acoustic enhancement a lot here, but I can see a more triangular shape of the bladder, and this would indicate a sagittal section. And when they measured it, they got 11. So then they used the bladder volume function, and she managed to fit more than a pint in her bladder. So pretty impressive, right? This person probably has to pee a lot at this time frame. And
was there an award for whose bladder volume was the largest in this, or that was just incidental?
I gotta ask that, but I don't think I've even had imaged my own bladder when I've had to pee, so I would be actually really curious to see how much I can hold. But
wow, end of an ER shift, you never know
yeah,
what you could get in
right.
there.
And then they peed, and so then they had to re-image themselves getting their own post-void residuals. So here's that same transverse bladder, a lot tinier. Looks like they figured out their gain issues, and so I thought that was a neat challenge where they had to do all the same measurements again, and her post-void residual was 40 cc's. So that's really good. And it also shows us that they understand the dimensions that go into a bladder volume measurement and how to perform it for clinical patients who really are having obstruction problems.
That's fantastic. I have a few things to add before we actually, let's go back into it for 1 second.
Sorry.
Just for and we can stay on that image is fine. So a couple of concepts that I just emphasize for the folks on the call, and for all the participants, by the way, if you have questions that come up while we're talking, go ahead and put them into the QA. Which is at the bottom of your Zoom screen, and we can have some of those fed towards us, and we'll do our best to answer them while we're talking and hanging out with you guys. The first would be that I don't know if everybody shares this view, but for me, I feel like the way to go into an ultrasound scan is to have an anchor image in your mind of what it should look like when you get the image you're trying to get. So instead of just kind of hunting around, you already kind of have your mental image of what you're looking for, what an ideal image looks like. And I think this is a great study in that the bladder is really rectangular, almost square in the transverse image as you're showing here. And if you want to skip forward to the measured sagittal image, it's got more of a triangular shape. In this case, it's almost getting a little spherical because this person has 800 cc's in their bladder, so it's going to take on more of a sphere shape as it gets really big. The other issue is, and I think I would have had the same feedback on if I were quality assuring this study around posterior acoustic enhancement, but you and I throw that term around, I'm not sure everybody would know what that is. So, as the ultrasound wave passes through a fluid-filled structure, the amplitude of that wave doesn't really get attenuated. Ultrasound travels tremendously well through water. So the echoes returning from the deep surface of that fluid-filled structure are going to be stronger than the surrounding echoes. So when you're imaging something like gallbladder or a distended bladder, you may want to decrease the gain selectively in the far field of the image, or you may want to decrease the overall gain, just to make sure you don't kind of wash out the posterior aspect of the bladder here. Because if you look deep to the bladder, it's just so bright white, it's so overgained down there that you might miss some detail like free fluid or something else that's lurking behind the bladder. So really cool study, and just wanted to point out the anchor image concept. The other thing is, and I'm going to put you a little bit on the spot, Rachel. Everybody knows in a transverse image, top to bottom, left to right, to measure the 2 dimensions of the bladder. But in the sagittal image, I see a lot of variation in the way that people measure the height of the bladder. Do you have any tips or any approach that you like to teach for your trainees in terms of, do they go for the greatest distance in terms of height? Do they go kind of left of screen to right, directly across? How do you like to have people measure bladder height?
Yeah, that's a great question, because I was going to comment on this too. So if I was giving feedback on this image specifically, besides the gain issue, I would say, hey, listen, I'm not entirely sure this is truly the height. I probably would have swung this out more into getting more of the maximal diameter, I guess, if you will, on this image. Now, they might not be wrong, because we know we have a 3D structure. It's not specifically uh, uh, a pyramid shape, but I probably would have taken this measurement out to there. I don't
Okay.
know, Mike, do you agree?
Yeah, I mean, I've seen it done from sort of the left side of the screen here, so directional indicator, the head side, from the upper segment closer to the near field, and then down across diagonally, almost like this. Although the upper edge, the cephalad edge of the bladder is off the screen clearly because it's so full. And then I've seen it directly, what would be cranial caudal, as you're describing, sort of just a line that's parallel to the skin imaging plane. Um, I have to say I've researched this at a number of different points in my ultrasound academic career, and there is no clear consensus. The AIUM has no guidelines about which way to measure. There's not really anything good in the traditional radiology literature, and even if you go to some of the bigger textbooks, you'll see variation in the way that this is taught. So I don't know that there's a really concrete definitive answer on how to perform that measurement. The good news is it's always important, we spend a lot of time talking about when to perform an exam and how to get a good image and how to interpret it adequately. But it's sometimes easy to forget about that last piece of like, what do you do it for, and what do you do with the results? And the reality is, if you're ultrasounding a bladder in someone who feels that they've emptied completely, and you see that they've got more than 150 mLs in their bladder, it's considered an abnormal post-void residual. And whether it ends up being 800, 600, 500, 1,000, it really doesn't have much of a clinical impact. So I try not to sweat it, but the OCD part of me always wonders if I'm measuring it correctly, and if I'm doing it right. But just last thing on bladder, we'll move on to a different application. Really interestingly, there are standardized lower urinary tract symptom scores that the American Urology Association, and then there's an international one called the IPSS that looks to say, okay, you have an elderly person in your primary care practice who's saying they're getting up a couple of times in the middle of the night to urinate. How well do those symptoms correlate with bladder outlet obstruction? And this was a surprise to me. They really correlate poorly. And there's a rational clinical exam series from JAMA that looks at the best test for an elderly person who may or may not have bladder outlet obstruction. And I'll give you a guess, Rachel. What do you think the best test is in an older man who's describing urinary symptoms to find out if they're emptying well or not?
The best test?
What could the best imaging test or physical exam or symptom test be?
Geez. I wonder if it could be ultrasound here. No?
In fact, you are correct. It is ultrasound. Yes, well done. Okay, so
Right.
we'll move on to something outside of bladder. But really, in the emergency department, we use this a lot for someone comes in acute urinary retention, or we suspect that, or we're troubleshooting a Foley placement or something like that. In outpatient primary care clinics, probably a big role in elderly patients with symptoms to determine who really would benefit from going on an alpha blocking agent. And, obviously long-term population studies would be needed to see what are the downstream effects in terms of surgical interventions and stuff like that when you identify these symptoms earlier.
And obviously, we could probably talk about this forever. But clinically, there are urology departments that are actually looking to buy some of these devices to calculate the bladder volume so that they don't spend $20,000 on a bladder scanner. So I think this is
Yep.
even entering their world just for this one purpose. All right, maybe I'll move on here and show you this one. This is a gallbladder. I don't know if you can make out the gallbladder kind of borders here. And they, I think, were instructed that they had to image the gallbladder after they had eaten. So they had to deliberately find their contracted gallbladder, which I think this is a pretty great view of a contracted gallbladder. It's relatively small. The lumen here is relatively small. The wall looks thickened just because it's smaller. And then it looks like this person measured the anterior gallbladder wall, which is a fairly good measurement, and it's where we would typically measure to avoid the posterior acoustic enhancement that's happening there. So I just thought that was kind of pretty that they could get that definition, because contracted gallbladders can be pretty hard to find sometimes.
Yeah, yeah, and a great point that the a couple of great teaching pearls that you kind of just dropped there casually. One, if you're going to measure the gallbladder wall thickness, measure the anterior wall as exactly as you mentioned. And two, when somebody comes in for their scheduled outpatient gallbladder ultrasound, they're instructed not to eat after midnight. That's so the gallbladder can distend and you can get a better image. But that wall cutoff of 3 millimeters as a normal wall thickness really applies to that population. And if you're looking at somebody who's just eaten, here's somebody with a 4 millimeter wall, but would be completely normal because it's just a contracted gallbladder and the wall's thicker as a result.
And so this would be an example of the gallbladder kind of, it's in its short axis, which makes it super hard to find. It's this little circle here. And it's kind of, I think it's really cute. So I like these images. I just think they're a little adorable. But let's see here. Let's see if they go on to looking for the portal triad. And that's something that I usually advocate that, oh, look, good. So I think, looks like they actually did try to follow the gallbladder wall and the kind of sonographic cystic pedicle into the portal triad. So that's a great view of the portal vein right there. And I want to see if they were able to get the common bile duct, maybe some of the hepatic artery. So they, through color on here, color flow Doppler, to see which were the vessels and which were not. And they have kind of outlining here in red of the portal vein. I'm not really seeing any colorization of the hepatic artery. This is probably not the most paralleled flowed image that they could get, which is probably why they're not seeing it. I have a suspicion it's going to be right there. Let's see how they do elsewhere. Look that they're still trying some color, but I think they tried to elongate the portal vein, and what they're seeing on top may be the common bile duct. This is something that's pretty difficult, I think, for us to do, and some places don't try, but in evaluation of, say, choledocholitis, which could lead to cholangitis, which for us carries, it's really high on our radar for septic patients who may not be able to talk to us or give us other clinical signs. This is pretty high on our radar for sepsis of unknown origin. And so looking here would be really good. And looks like they thought it was also common bile duct, and they measured it to be about 0.2 centimeters, which would be normal.
Fantastic.
Yeah, so I think they did a really good attempt here on their contracted gallbladder and finding the portal triad.
Awesome study. I'm gonna ask you to stop screen sharing for a second, Rachel. I want to show you just a contrasting image, which is complementary to what we were just talking about. So here's, you know, I don't know about you, but for me, when I can't find the common bile duct and I'm wondering about it, it's almost always because it's normal in caliber and it's very, very thin. So, you know, here's just a contrasting image. We've got portal vein with continuous color in it. You're seeing some intermittent color in this circular structure, this small structure right there, which is hepatic artery. And then the avascular structure lying right on top is common bile duct. So for any of the viewers and folks on the webinar with us, if you struggle to find the common bile duct and you're confident you're looking at the portal vein and you're seeing maybe some wispy thin structures on top of it, almost certainly the common bile duct is one of those structures. You may have a hard time identifying it if it's normal. If it's abnormal and enlarged, and in this case, I think we ended up getting a measurement here. Let's see, that's a still image. Yeah, so 9 millimeters on this common bile duct. This is something that's been called the double-barreled shotgun sign, where the portal vein and the common bile duct are both the shotgun barrels, and then in between the two is one of my favorite named signs in ultrasound. This is the olive sandwich sign, where you've got one bun, the other bun, and a little olive in it, which is I don't know who comes up with these names, but that's the hepatic artery sandwiched in between. And just a good pointer that if you're really struggling around finding the common bile duct, it's almost always because it's normal, and don't sweat it too much.
I'm glad you brought that up because I've been dying to figure out who actually named it the olive sandwich sign, and I think I emailed you once being like, "Did you name it?" And because people think that we named
I
it, and I don't
wish.
think we did. So, anywho,
No, I think that's an old school radiology naming at some point. I'm not sure who deserves the credit, but maybe we can send some of send a medical student or a rotating resident on a wild goose chase to find out the origins of the olive sandwich sign.
that's great. I just wanted to show you maybe one more, maybe that way we can get to some of the submitted images, but I thought this was really cool. So this trainee completed the Hopkins Ultrasound Challenge, and one of their assignments was to get this view. And I don't, this is really not a common view that we get, but for us in the ED anyway, trying to find this particularly in patients with migratory neurologic symptoms and combination with hypotension or stroke-like symptoms with combination of hypotension and pain, back pain or chest pain. This is a view that we sometimes try to get. This is called the suprasternal notch view, and you're literally trying to image the arch of the aorta to see if there can be either a dilation or a dissection flap that is visible within the arch to make sure that we're not having an ascending or arch dissection. And so this trainee managed to actually, I think, get a pretty decent view of the arch that's right here, along with the branches. And what impressed me even more was that they did appropriate labeling, which was great. You know, I'd love to see this kind of pretty labeling. And then even labeled and found where some of the pulmonary branches came off. So I thought this was a really impressive image coming from an intern.
Yeah, that's not only a great image acquisition, but you know, there's very little as complex anatomically as the base of the heart and the origin and branching of the great vessels. And if you're just getting a 2D slice to have a sense of what's pulmonary artery, what's lung component, what's arch, that's really quite a great comprehension of what they're looking at there, and a really nice image.
Well, Mike, do you want to
Awesome.
go through some of the submitted ones, or?
Yeah, sure. So we had quite a few submitted images from participants, and not not a chance to be able to go through all of them, but I did select a few that we can take a look at. We'll start with this one just because it ties in nicely to the last study that you were showing. So, you know, we're in an abdominal preset. We've got our depth set at around 9 centimeters. And there's this large structure in the middle, seems kind of pulsatile, irregular wall to the inside. What do you think is going on here, Rachel?
Well, that's really hard. It doesn't seem like it's pulsating very well. So I'm very concerned about the circulation that's happening in here. I mean, they say abdomen, so I'm going to have to guess that this may be like, and where are they? If they're centrally, then it probably is going to be aorta, or if they've zoomed into the right upper quadrant, then this could be a messy looking circular structure which might be gallbladder with a whole lot of fluid around it. So I don't think it's that. But
yeah, I'm going with aorta.
Yeah,
I'm going with aorta, and this one's from Brian, who's a internal medicine resident in Colorado. You know, if let's assume this is aorta, I would bet money this is aorta. It is pulsating. It's not zoomed, and we can tell because there's no little zoom box on it, and we've got the calipers down the side. So I'm going to feel confident that it's. Let's see, it starts at about 1.5 centimeter depth. This is the cheap way to get a measurement if you didn't do a measurement. So 1.5 down to about 7.5. So 6 centimeters anterior posterior diameter. So that's concerning. I know John Martin, our CMO, is a vascular surgeon, and he'd be getting excited about this. And then off on the screen left here, probably vena cava. Not really 100%, would definitely want to see more. I guess the other possibility is that you've got a retroperitoneal leak there, and that you're actually seeing some blood outside of the aorta. From a image review standpoint, what would you want to see other than maybe some labeling to get a better sense of what we were looking at?
You know, obviously with the worksheets and things and the preset, you probably would be able to tell anyway. But the one thing I would say is maybe just increase the depth actually just a little bit so that I could clearly see that there would be a a curved horseshoe spine. And that landmark would let me know that this vessel on top of the spine is truly aorta. That would be probably the one thing I'd like to see from this image. But other than that, great, beautiful false lumen and true lumen here, which is a little scary.
Yeah, so you know, this brings up a number of key points. One, the idea of when you do measure an abdominal aortic aneurysm, there's often a lot of mural thrombus, there's a lot of clot in the wall, and that the measurement should not go from lumen to lumen. You will underestimate the size by a lot. In this case, you'd call it a 2.5 centimeter aorta, which would be normal, and this is clearly far from normal. So you want to go from outside wall to outside wall. Other issue is, you know, we're back to my philosophy of anchor image, where you have in your mind already, you know, if I could see the vertebral body deep to this thing and a shadow coming off of it, that's the image you have in your head of what an aortic aneurysm should look like, and what a normal aorta should show is that vertebral body with shadowing underneath. So more depth, always a good idea when you're first starting a scan. I always tell new learners, start with way more depth than you think you need. And then once you're sure that you're looking at what you're looking at, decrease that depth and kind of fill the screen with the object of interest. And then I think we actually had a comment come in from Al Savage. Hey Al, recommended 2 views, which absolutely, we only had 1 view shared by Brian in this case. We don't have access to the whole study. I'm going to give him credit and say he probably got a long view as well, but definitely whenever you're trying to define structure, 2 orthogonal planes, 2 perpendicular planes, really useful. And then color flow, right? If you want to go ahead and see if this is a vascular structure, I mean, I do think, you know, it's pretty clearly pulsating, but you know, if you're able to see color flow in the lumen, no color outside, or who knows, you might see some color kind of leaking out this way right here, making you think it's ruptured. and you might gain some additional useful information by putting color on. So that's a great tip, and agree with you, Al. That's a good idea.
I think it's safe to say, like in anything that we do, two orthogonal planes or two views at least is probably necessary. Just to make that point that, you know, even though we are isolating these images just for the purposes of image review, in most cases, the scans that get submitted have many views, 5, 6, 7, or at least 2.
Yeah, 100% agree. You know, I worked closely with a trained sonographer who was also a vascular technologist and an ultrasound technologist who said you haven't seen a structure until you've seen it in both planes. And I think that's a great tip. You know, that's the kind of stuff that will stop you from calling something an abscess when it's actually like a thrombosed vein. If you just followed it all the way through and then turned, you'd say, wait a minute, this is a longitudinal structure. This isn't an abscess, right? So always a good tip to make sure you're looking at everything in 2 planes. I think there's occasional exceptions. We get away with 1 plane for some lung imaging. We get away with you know, sort of 1 coronal plane in a sweep for some of the fast exam stuff. But in general, 100% agree, 2 planes for everything you look at. Okay, I'm just going to take a quick peek at the QA because it looks like there was one more. Oh, so Brian's popping in. You don't have to be that honest with us, Brian. He said he didn't get a second view of the aneurysm. That's okay. I was trying to give you credit. And which view would I use for more depth? This view is great, and honestly, you're probably just about 2 or 3 centimeters shy of having enough depth. You're at 9 centimeters here. I'd probably have it at about 11 or 12, and I think you'd see the vertebral body and some shadowing at that point. And you could keep the depth the same for the longitudinal image.
Someone asked if this could be like a fresh aneurysm or, you know, a dissecting aneurysm. It's hard to tell on this image itself, but I think actually it could be just by the characteristics of having some hypoechoic areas within the thrombus that's outside this main false lumen. So there you got some fresh areas of hypoechoic stuff mixed in with more chronic thrombotic processes. So something tells me maybe this is broken recently, clotted, broken, clotted, broken, clotted.
Yeah, it does. It does have that mixed echogenicity. Makes you wonder if there's some layering of fresh blood and clot for sure. So cool. Well, we could like even just like the bladder, we could spend the whole rest of the time on this one image, but we're going to move on. I do want to give Brian one more little props here for this study, which I thought was really cool and is a cool example of pre-procedural safety improvements that you can get by incorporating POCUS into your practice. And I'll just describe what we're seeing here, and then Rach, I'm sure you'll have some tips and thoughts on this. But this is a pre-paracentesis color flow image of the lower quadrant of the abdomen. I don't know if it's the right lower or left lower quadrant. So Brian, if you're still on labeling, just throw in a label and that'll tell us. But we've got skin and soft tissue here, muscle belly, and this color flow here, which are the inferior epigastric vessels. And just above that is, or excuse me, just below that, it's all anechoic. That's because this is the ascites fluid that they're getting ready to go after with the paracentesis. So, you know, ascites patients, cirrhotics with ascites, generally their platelets are not the best and their coagulation is not the best. And if you can avoid accidentally sticking one of the superficial vessels in the abdominal wall before you get to the abdomen, that's a plus. So I like this. Any tips on this? Is this something you do before paracentesis, Rachel?
You know, I actually do. And the reason being is that, you know, usually these arteries are fairly midline, but in an ascites patient, because their abdominal girth has grown, these arteries can transplant more laterally. And okay, the chances of hitting it is fairly slim, but I once did a paracentesis where we drew out frank blood, and then we were like, oh, did I hit it? You know, and so we were freaked out for a while. And so now I just kind of do it before everyone I do. Fortunately, it turns out that it was hemorrhagic ascites from unfortunately malignancy and not me hitting the arteries, but still, that was my little lesson in doing this.
Yeah, there are few feelings more like stomach sinking than drawing fresh blood out of something that you didn't think was going to be bloody and feeling like maybe you did something inadvertent along the way. I've been there,
Yeah.
and I have to say sometimes it's been because I did something inadvertent along the way. But I agree. I think in general for procedural guidance, if you're going to be using ultrasound for procedural guidance, which for most things you should, we're not going to get into a deep discussion about whether you need to for a knee arthrocentesis or some of the other like superficial abscess drainage that's already pointing. You don't always need ultrasound for everything, but if you're planning to put a needle into something you can't see with your eyes, I'm generally using ultrasound for that. And when I do, I think putting color flow on the expected path of the needle is a great general practice, whether it's an inferior epigastric and you're looking for ascites, or you're planning to do a nerve block and you want to make sure you're avoiding underlying vessels. I think it's a great approach. So thanks, Brian, for submitting, and we'll move on to one from Eric Martinez, who sent us with patient consent to share some clinical details, some images from a patient with AIDS and a recent fungal pneumonia. So here is, and there's probably a select few participants who will get the snarkiness of the comment I'm about to say to Rachel. But Rachel, this is an echo in an orientation that you guys do reversed at Yale. So there is some imaging debate about which way the LV apex should be oriented, and whether this should be flipped mirror image in emergency medicine versus cardiology. And Rachel and Chris at Yale have had long, interesting, and well thought out arguments to put the apex of the heart on this side and the directional indicator on this side. We're not going to cover that today because that would be a 2-hour webinar. But this is in the traditional echocardiography view. So the indicator on the screen is to the right, and the indicator on the probe is to the patient's right shoulder. And what are we seeing here that looks normal to you, and what are we seeing that looks abnormal?
Yeah, so first off, I'm guessing I have a little bit of lag, I have to say, with the beating, but if I notice first, there is a kind of small, probably not terribly significant pericardial effusion here. And then if I'm sort of looking at the left ventricle, I don't know if this patient might have a little bit of arrhythmia or not. There seems to be like a hyperechoic spot almost right where your arrow is. And it may be some papillary muscle, but it seems rather bright to me. And I think I see other aspects of your mitral valve that are connected to where the papillary muscle should be. So that could be abnormal.
Okay, absolutely. So parasternal long axis view, just for participants: left atrium, mitral valve here, left ventricle, aortic valve, aortic root. The right ventricular outflow tract is up here. This is pericardial fluid, so deep to the left ventricle. It's superficial to the descending thoracic aorta, which is here. And that's really how you tell the difference between pericardial and pleural fluid in this image. Is pericardial fluid will come around and kind of track superficial between the heart and the descending thoracic aorta, as opposed to pleural fluid, which will be located more out here. I also looked at this and, it seems almost like a calcified papillary muscle. I'm not totally sure what I'm looking at here. And I agree with you. I think multiple views would help. This is a great example of, you haven't seen something until you've seen it in two planes. And I would like a little bit more information on it. I also see you have company, Rachel. Who can we greet to the occasion?
Oh, this is Doug. Doug is now an MS2 student, and he's already a POCUS kind of whiz here. But he might help us with some modeling later on.
Awesome, fantastic. Welcome. Thanks for helping out. Thanks for joining. We'll move on to one of the other images I wanted to. So here we are again, just briefly. There's that structure again, and
Yeah, it's kind of prominent. It's really prominent in that apical 4 chamber view.
See if we can take a look at it from a subcostal. I'm getting more and more convinced that it's part of the papillary apparatus there, but it is remarkably hyperechoic on that apical and on the parasternal long. It's good indication that you still have pericardial fluid circumferential. It's small. It's not a large effusion, but it's definitely beyond just a physiologic effusion. So and I think we'll wrap this study.
Oh, sorry. I was just going to say, for image review purposes, I think this would be an example of one that we would spend more time on quality assurance for, just because you have your experts questioning some aspects of what we see here.
Yep. Absolutely. So this would be in the context of a regular QA session. This one would take up some time for sure.
That's a really nice spine sign, though.
Yeah. So you can tell even off the thumbnails what we're looking at down here. So this one, this is a great image, and I'm going to have you explain the spine sign. I'll point out the anatomy first and then talk about what this means. But so, this is a coronal view. So the probe is over on the right flank. This is liver, diaphragm here, this curved structure. We've got a little bit of the upper aspect of the kidney. And lung is here. And for those of you familiar with lung imaging, you know that lung shouldn't look like a solid organ. So the fact that it does look like a solid organ, you already know something's abnormal. And then you've got this anechoic or black collection inside the thorax above the diaphragm. The probe indicators up here towards the head. So there's some pleural fluid in the right thoracic cavity. And then what's going on down here?
Yeah, so this is something we call a spine sign. And essentially in normal lung, the air from the lung would have scattered the sound waves so that nothing could be imaged really in this space. And so you would normally never see the thoracic spine entering into the kind of cephalad field of view. But when you have fluid there, the sound wave it attenuates the sound wave. And so the sound wave now has something to kind of travel through, and then it is able to hit the thoracic spine. And then so if we see the thoracic spine extending from the abdominal spine, we know there's something pathologic there. So yeah, this is really pretty though.
Yeah, absolutely. And could we have a little bit less depth? Maybe. If we're going to nitpick technique, I think you could fill the screen a little bit more with what we're looking at, but it's a great image. It's diagnostic. I mean, this is a patient with, likely protein calorie malnutrition, just given the background of the clinical history. And you can see the spinal canal deep to the vertebral bodies. I mean, you can kind of see all the anatomy with ultrasound here. One thing that you drop all these pearls that we just move quickly past. I want to rewind for a second. It doesn't mean it's fluid. Right? So anything in the chest that allows ultrasound to transmit through it without scattering, and that could be a lobar consolidation. So if you had a big right lower lobe pneumonia and no pleural fluid, you'd still see the spine sign coming up past the diaphragm. In most patients, it'll stop right here. You'll see the spine below the diaphragm, but you won't see any spine above. It'll just abruptly disappear. And if there's fluid or consolidation, you're going to see the spine continue past the diaphragm. So it is just, you don't need to see that to confirm an effusion. And you may have an imaging plane that doesn't show you the spine. But if you ever see the spine going up past the diaphragm, I think that's a great sort of call to attention to pay some thought to what's happening in the right chest or the left chest if you see it on that side. And then we've done a lot of biliary today between contracted gallbladders and common bile ducts. And I thought this was a really great image. So we're in an aorta and gallbladder preset. We've got the gallbladder here, and there is some fluid outside the gallbladder. right? We've got this sort of anechoic, irregularly shaped fluid right here. It's got kind of spiky edges. It looks like free fluid right in there, filling in this potential space. So there is some ascites there, most likely. And we don't have a wall measurement or anything, but what do you think's going on inside the gallbladder?
I think that's some rather thick, nicely heavy sludge there that we would treat as symptomatic obstruction because it's basically layering down, and we have evidence of cholecystitis with the pericholecystic fluid around it. That means it is obstructing.
Yeah, so I mean, we've got echogenic material within the gallbladder lumen. It isn't shadowing, which is why Rachel's calling it sludge as opposed to a stone. There's also kind of the same phenomenon we saw with the bladder, just to kind of wrap up and reintroduce that same theme, is the echotexture of the liver here. It's brighter deep to the gallbladder than it is adjacent over here. And this is posterior acoustic enhancement that we're seeing within the liver parenchyma as a result of the fluid getting basically a free pass through that fluid-filled structure, the sound wave getting like a free pass through the fluid-filled structure instead of attenuating through liver tissue. So that just tells us this is fluid-filled, the fact that it's brighter down here than it is in this adjacent liver tissue and this adjacent liver tissue. So just another cool tip. And then, is this acute cholecystitis, or is this a patient with gallbladder sludge who also has ascites? Again, we're seeing something in one plane. We haven't measured the gallbladder wall. We don't have the clinical context to know, is this somebody with a fever, infectious symptoms, or abdominal pain? And there are other causes of pericholecystic fluid and gallbladder wall thickening outside of acute cholecystitis. So I'd probably table that and say, I want to know more. I want to see some more images. But I think, if I saw a patient coming in to me with acute upper quadrant pain and this kind of gallbladder, I'd be very concerned that this was acute cholecystitis. Just a pretty cool study from cardiac all the way through lung into abdomen. So Eric, thank you for submitting. I think we probably have time to, we've got about 10, 15 minutes left. I think we probably have time to look at a couple of other images, which I'll pull here. And just a good contrast image. We don't need to spend a lot of time on this one because I don't want to beat the gallbladder to death. But here's a long view of a gallbladder. We'll look at one that has some that has a clip first so you can get some context. And there's some bile in there, but there's also a whole lot of layering stones. And this is just another good example of a nice wall measurement. So we're measuring the anterior wall. It's almost a centimeter. This is pretty convincing for acute cholecystitis. And why don't we do this one real quick, just because it's kind of outside of what we've talked about. So it's a personal story that I would share with people. So earlier this year, I bought a new bike. I was pretty excited about it and took it out for my first ride, and helmeted and everything, and managed to fall off it on the first ride. The details I won't share with the group, but it was embarrassing at the very least, and I had a nice closed head injury on top of my other trauma. But after limping back to the house, I took a look with ultrasound because I was having quite a bit of lateral chest pain and wanted to make sure I hadn't had a pneumothorax or anything. I knew something was wrong. So still image, and I'm looking at a lateral rib here. So this one doesn't really require a whole lot of explanation. You see a nice smooth bony cortex, and then a step off, and then continuation of the bony cortex here. So this looked like a rib fracture in a still image, and then that's just looking at it in a mobile image with the lung sliding down here. So that's a good sign, but clearly a step off.
Mike, that's pretty cool. But I got two questions for you. All right.
Yeah.
One, what kind of bike did you get?
It's like a mid-range gravel bike.
Okay, I don't know what that is, but I like.
It's like a road bike that you can take on gravel and some light trails. It doesn't have a suspension like a mountain bike.
Got it. And then I want to know if you serratus anterior plane blocked yourself.
You know, I definitely thought it would make for good entertainment if I did a block, but I have to be honest. I complain about lots of things in my life, but pain tolerance doesn't tend to be a huge one for me. I'm just lucky. So I took some ibuprofen and limped around, and I was okay. But I did think about it and chose not to. Probably because I had a hard time staying awake for the next few days with my head injuries. All right, so but you know, rib fractures on ultrasound. This is a great thing for people to consider. So you know, we think about getting either X-rays or maybe CT scans or maybe just clinical judgment for whether someone has a rib fracture when they come in with post-traumatic thoracic pain. And the difference between chest X-ray and ultrasonography for rib fracture, it's like mind-blowing. And this is, you know, these are data that go to like the 1990s in American Journal of Röntgenology. I mean, this is not a point of care application that a bunch of like enthusiastic ER docs came up with. This, you're looking at, you know, 8 to 10% of rib fractures detected on plain chest X-ray in some studies, and 80+% detected with sonography. So all you have to do is just make sure you're in a musculoskeletal or a soft tissue setting. You're being gentle with probe pressure, because as opposed to cardiac or abdominal scanning, you really want a lot of pressure to get a great exam. Nobody's going to tolerate you doing a lot of pressure when they have a rib fracture. So light touch, lots of gel, and the ability to just look right away and say, you know, either, hey, you've got one rib fracture, the lungs sliding, you're pretty good, we're going to put you on a pain regimen. Or alternatively, like happened to me 2 weeks ago, older patient who had fallen, had 4 consecutive rib fractures that I saw right when I went to go look for a pneumothorax, because the paramedics felt that they heard decreased breath sounds on that side, which they probably did have decreased breath sounds. I don't use a stethoscope because I have an ultrasound, but they were probably splinting. And you could see 4 consecutive rib fractures. I walked out of that room and sent a page to my trauma surgeon and said, hey, you know, I'm going to keep working this person up. They're stable, but they're in their 80s with 4 consecutive rib fractures. They're going to need to come into the hospital. So, you know, really, I think an underrated application for point of care ultrasound. And I'm a big fan of rib fracture scanning, even when it's not my own ribs. All right, we've got about 10 minutes or so. Do you want to try and do a little bit of live scanning? And we'll see how that works.
Does anyone, do you have a particular thing that you want us to scan? I'll throw it out to the audience. If not, we can try to get Doug's suprasternal notch.
Yeah. I'm keeping an eye on the Q&A feed here to see if anybody has particular things they want us to try and scan live. And if you do, go ahead and throw it in there. Somebody wrote a radial artery, so that's an easy one. We can go ahead. Thyroid.
So it says that you're away on the teleguidance, so you have to activate
Oh yeah, sorry, I was on my my image review screen. Hold on a second, I am joining, and I should be available for you now.
Okay, let's see here.
Okay, wow. Audience is amazing. There's like, you know, 40 different ideas for what we should look at.
Cool. Okay.
Yeah. So you want to mute on your side. I got you. Actually, I'm not getting feedback, and I can see you, Rach. Do you see me?
Yeah. Now I do.
Okay. So I'm going to go ahead and share my screen on this side so the audience can see what we're seeing.
So you had a radial nerve, you said?
Yeah, so, well, radial artery was one, thyroid was one, aortic arch, erector spinae, cricothyroid membrane. I think we may have to set up a second scanning session. Why don't we do, Why don't we do the neck, because there's a request for aortic arch, there's a few requests for thyroid, and there's a request for cricothyroid membrane, and all of those are in the same general real estate. So we can start off there.
Okay, thanks, Doug. So I changed myself to MSK preset, and it'll be cool because I'm going to be far away from my screen, and actually Mike can take control over something. So Mike, I might need you to give me some pointers here, Doug. Here. Thanks. Okay, so my probe marker, I'm going to keep pointed towards Doug, who's our patient, towards his right. And I'm just going to put it on his
Great.
right there. And so if I'm right in the middle, so I'm seeing the tracheal rings, and I can scan.
So come back down for a second and just pause for a sec. So you had thyroid isthmus just a minute ago.
Yep.
Exactly. So this is all thyroid isthmus going over the trachea here. And we've got right lobe of thyroid out there. Carotid artery. Sorry, I was trying to trace it, but we were moving. That's okay. No worries. And then we've got airway obviously deep there. So why don't we take a look at the right lobe of the thyroid? We'll come over.
I'm coming over. There's a little bit of a lag.
There we go.
Yeah.
Yeah, that's okay. I think we're straining the system with doing this and a simultaneous Zoom. It might just be my my Wi-Fi. But right here we've got carotid artery. We've got sternocleidomastoid up there. We're not seeing his internal jugular vein because he's standing upright, but if you want to try and Valsalva, we might be able to see your vein pop out. Yep, okay. There we go, right there. So there's IJ out there. And, you know, if you ever need a central line, you've got a lot of distance between your IJ and your carotid, you'll be in good shape. And then if we want to fan through the thyroid, we can just come down towards his feet till we disappear the right lobe, and then come back up towards the head. And you can evaluate the entire lobe of the thyroid here. And you just, you know, like we said before, you don't see something unless you've seen it in both planes. So you guys watching, notice that, that Rachel's really slowly, deliberately sweeping through and getting a full image of the lobe. And then she would come off to the right side of the thyroid again, and then just turn into a long view. Exactly. And now we're seeing a long view of the right lobe of the thyroid. So, you know, you can do measurements. You can go ahead and put color flow on if you were to see a nodule and wonder if it was vascular or avascular. But that's one of the things people wanted to see. Why don't we, we're running low on time, so why don't we take a quick look and see if we can get a suprasternal notch. And if I'm going to change you into a cardiac preset here.
Thanks.
And I think you might be a little jalapenic, but
yeah, I am kind of jalapenic here. Hang on. Or you want also lean back just a little bit, like, yeah.
So for everybody listening, we're right in the notch, the suprasternal notch, and Rachel's going to turn the indicator so that it's kind of pointing off towards his left shoulder a little bit. And we're going to see if we get a view. Not everyone has a great suprasternal notch window, and there are definitely times where you get a good one and times when you don't. And I don't want to misquote our friend's literature, but one of our friends did a study on this, and I want to say it was around 60% of the time that in all comers you're able to get a good suprasternal notch. So we don't have high expectations for this one, but in case we luck out, we'll luck out.
No, I'm not getting a great image. I
Yeah.
get it very superficially, but I can't arch down.
Okay.
I
Well,
just have too much.
yeah, we don't want to put too much pressure right on his neck and have him pass out on live webinar. It'd be embarrassing for everyone. Well, thanks for the thyroid demo. I think we should definitely set up a teleguidance session with a little bit more of like a, you know, this session was really set up for image review, which I think we got through surprisingly a lot. The one thing I would say about the the thyroid study that did pop up in the Q&A is why MSK versus small organ. You could absolutely do it in small organ. That's fine. You know, we can go ahead and set up a time for some more live scanning, but I'm really happy we got through as much image review and tips that we did. And Rachel, thank you so much for coming on and sharing your expertise and all those pearls with us. It's awesome to see you, and really grateful to have you let everyone benefit from your expertise.
Oh, thank you.
All right, take care, everybody. We'll see you next time.